Hello, everyone. My name is Edward Chang. I'm an adjunct professor in the computer science department, Stanford University. My presentation today is SocraHealth, which stands for SocraThings, which is a platform and to improve disease diagnosis accuracy. And my outline of the talk today started with a brief review of AI applied in medicine in the past about 50 years. And we try to explain why so far the deployment has been quite slow. And finally, whether the foundation models can come to help to improve disease diagnosis accuracy. And we know this symptom checking paradigm or process has been an age-old familiar process. When a person is in discomfort situation, a doctor or a helper will go through a series of symptom checking, asking for whether a person suffers from certain situations, and finally do a prediction of diseases. If the prediction cannot be made, means the evidence is insufficient, the physician would further refer the patient to do additional tests and maybe doing triage. Okay, and the AI has been trying to facilitate this process since 1970. In the beginning, expert system was established by encoding the doctor's knowledge in a computer. And the misdiagnosis was quite high because even you can limitedly to encode a doctor's knowledge, but there are just so many different diseases. So the system was never be comprehensive enough. And in the 80s to about 10 years ago, and the AI field tried to develop much better tools, including the Bayesian methods or supervised machines. But however, because of lacking training data, the accuracy was still not there. And we haven't just seen any major deployment 10 years ago. But even after this data-driven era, we still haven't seen the radiologists lost their jobs as predicted. I'm going to depict why that was the reason. And this picture shows AI winter came to the AI community twice in the past, in the 80s and also in the 90s. And especially in the healthcare domain, the major reasons are because the prediction accuracy, disease diagnosis accuracy is not there. Once it's not there, there's no trust between the patients, doctors, and the computer scientists. And also, of course, the hospital worry about the legal and ethical issues. Who is going to be responsible for a misdiagnosis if diagnosis comes from AI? Okay, in the data-driven era, since about 10 years ago, because of the success of AliceNet, so there's a new hope arises. And the hospitals and computer scientists to start to collect digital data, including individual medical history, family health history, and so on and so forth. You have a big set of repositories of medical records. And in addition to medical records, we can also using IoTs, Internet of Things, to collect wellness data. And everybody probably knows using Apple Watch, we can collect our blood pressure, temperature, heartbeats, and a lot of wellness signals. And collectively, and research consider if we have all those kind of data, just like Tesla collects billion bytes of data every day. So at time X in the past, if we don't feel comfortable, we go to see a doctor to do diagnosis. But if we can continuously collecting lots of healthcare and the wellness data, then even before we feel discomfort at time X, it's possible to predict there could be a risk in our body. And we can probably go to see a doctor before even we got sick. And so this was called preventive medicine or precision medicine, hopefully with additional data, with a robust artificial intelligence algorithms. Unfortunately, still, we are not there. So if you look at this last red rectangle, it seems like both Google and Stanford University, led by Andrew Ng, last year, they pretty much got out of healthcare. So according to Google Health, and this is a public record, they say we will continue to stay in healthcare research, but we are not going to do prediction. And Andrew Ng last April at AI forum conducted by Stanford Medical School. He said, well, he still stood behind his papers, but he considered the AI suffered from a robustness problem. So accuracy is still an issue, which I'm going to explain in the next slide. What do you mean about robustness? And Ludwig Schmidt, a professor in University of Washington, did a very comprehensive study. So he collected all the computer vision models, including VGG, AlexNet, and so on and so forth, and using their original test beds. And he plotted the next important chart. So there are two lines here. And these two lines, if the testing condition is altered, suppose you have a piece of image, you say, I'm going to change a few pixels. So you vary the testing image. And if the robustness of your AI system is very good, the accuracy still should be maintained. So he has this black dot line on the top. Suppose your model has very strong robustness, then even with changing the testing image slightly, the accuracy should still be there. So you look at x-axis and y-axis, the accuracy should be identical. But he considered using all the benchmark of computer vision done in the past 10 or 20 years. And even they have varying accuracy because some models are larger and some models has smaller parameters and some model has more training data and less training data. But the problem is not the relative accuracy of themselves, it's between this robustness accomplished line ground truth and their accuracy which can be accomplished. And this gap comes from the varying of the testing data or the noise of testing data. And in medicine, it's all evident. If you go to different hospitals, they have different X-ray machines, they have different CT scan machines, and even they have the same machine, they may have different tuning, they have different image format, resolution, and so on and so forth. So as Andrew Ng said, well, if I train a model and in Stanford, using Stanford data, then I walk down to the street to try to use it in a different hospital, the accuracy was just drop substantially, sometimes even more than 15%. So what can we address the issue? And maybe we can, maybe we cannot, but let's take a look at using foundation models. Can we improve diagnosis accuracy? So diagnosis accuracy, if you look at this picture, it's pretty much, this is very robust, published in 2018. So on the left-hand side, you have a list of symptoms. And then on the x-axis, you have different diseases. So this table can be interpreted easily. So based on the symptoms on the left, we can see this small rectangle here. What's the probability one person has pain and suffer from influenza, right? Then you can say, oh, this is 0.0 whatever percent. And on the other hand, you can say, if I have certain diseases, and what would be the probability you have certain symptoms? So both ways you can do mapping. And of course, the question is, number one, whether the probability number here is accurate or not. But you know, there's impossible you can have accurate number here because there are a lot of other dependent variables, including a patient's medical history and maybe the environmental issue and so on and so forth. And so this table cannot be served as a static content, right? This table has to be served based on the contextual information of a patient. If a patient is female, then there's no way the female will get prostate cancer and so on and so forth. So it's evident we can understand that. Just like LLM today, ChatGPT, we need to provide sufficient context. Otherwise, the answer provided by the chatbot may not be very nice. So how do we incorporate the contextual information into it, and how can we ensure the hallucination wouldn't occur and the biases wouldn't occur? So if you look at the table here, the bias is definitely there. This is the biases by the training data, the default biases. We have to get out of these default biases. And misdiagnosis has been a big problem in the US. According to a recent survey conducted by Johns Hopkins professor, and the misdiagnosis is about 5%. And this caused a lot of suffering and definitely costs a lot of money. And we propose using SocraHealth. This is a method basically using LLMs and trying to discover insights, new information, but more importantly, try to eliminate hallucination and the biases. For details, we don't have time to go over, but we have another paper in the conference. Actually, also you can visit the site, SocraHealth.com. It has listed about 10 papers and worthwhile to get into the details. But basically, the spirit behind SocraHealth is we have multiple LLM agents. They organize a debate situation, and they kind of providing arguments to support their own positions. And then we use conditional statistics. This is critical because suppose we say, okay, agent A, agent B, one is from GPT, one is from Bard, and agent A, you oppose the diagnosis of agent B, right? You force them to disagree with each other and come up with justifications. By doing such, they are free from these inherited biases from the training data because they are forced to be polarized and taking an extreme stand. And after a few rounds of debates, not only the contextual information can improve over and over, but by doing reasonableness, the hallucination, the room for doing random kind of arguments or hallucination get reduced substantially. Again, for details, you have to read the previous paper. And let me give you a couple of examples how we use SocraHealth to conduct disease diagnosis. So we have moderator is like me. I'm not going to do diagnosis because I consider I cannot ask good questions in front of LLMs. I would like LLMs to debate with each other because they are so clever with a lot of polydisciplinary information encoded. And in a situation, we use GPT as one agent and the Bard as the other agent. And we conducted 2 experiments. The first experiment, we provide a list of symptoms on the slides, and we ask both agents what would be the predicted diseases. And the Bard saying, well, according to the information provided, this patient should suffer from jaundice. And it provides a list of justification, which you can read in details. And then GPT, in the first round, it predicts to be hepatitis. And then the 2 agents start to defend their own position, their own prediction. And then after a couple of rounds, at the end, Bard make concession saying, well, yeah, jaundice can be considered as a symptom rather than a disease, and hepatitis has higher probability. But they don't just stop here. So 2 things. One is even hepatitis meets the ground truth of the training data provided to us, which is from the CDC. But the ground truth itself can be mistaken. Remember this 5% misdiagnosis, right? So there are 2 possibilities. One is even both agree with hepatitis ground truth can be wrong. So, or in a case, maybe Bard was wrong and he made his correction. But rationally, you should say, what are missing? If you can be provided with additional information, and can you make a better prediction? So both of them say yes. If you can ask the patient to provide additional symptoms like onset of duration and the severity of and the trend of the symptoms, and also other associated symptoms, and you can conduct additional lab tests like liver function tests, hepatitis panel, and so on and so forth, then the diagnosis can be much more certain. So this is extremely reasonable. We ran through the whole process with some physicians in Asia University, they consider to be extremely valuable. And let me give you another example. Suppose again, GPT and Bard, they debate with each other, and this is another list of 11 symptoms. And this time we ask GPT to go first, and GPT made predictions of 3 different diseases, dengue fever, then Zika virus, and so on and so forth. And the Bard provided a different list. Here, actually, GPT did not provide probability, and Bard provided probability of the 3 predicted diseases. And definitely the lists are different, right? So I asked them to debate again, and the Bard in the second round changes the disease list and also assign different probability. And in the second round, Bard say, okay, yeah, the dengue fever has higher probability. It agrees with the ground truth again, and also agrees with GPT. And likewise, in the end, they suggest additional symptoms should be probed, and also a list of lab tests like this dengue NS1 and antigen tests and so on and so forth. And they also recommend we need to talk to the patient to understand his travel history and maybe time of the year, because only in the summertime, mosquitoes exposure can cause a person to have dengue fever. So this is, I think, the contributions of SocraHealth in this diagnosis scenario. Again, you put two really smart agents to be at opposite positions to debate with each other, and they could conduct information discovery, and they may come up with better questions to ask the user to provide more contextual information. For example, travel history is a contextual information, and if you have medical record, medical history will be even better, right? So two things again to keep up. And once you have gone through the process, suppose the misdiagnosis happens and get detected, we can come back to modify this table. So in time, this default table will become more and more accurate. But again, we mentioned in the beginning, just having this table is for sure, it's the average statistics of all the human beings. So for each individual person, we have to go through like LLM-like kind of query and consider an individual's contextual information to do personalized medicine. And limitation of this work, because we have only conducted a limited number of experiments, definitely more thorough experiments need to be done. And in any way, we consider even in the beginning, this can be a very good second opinion system, because in a hospital with 5% misdiagnosis, we can run a batched verification kind of program in the nighttime, go through all the diagnoses during the day and identify high risky or uncertain cases for second opinion or examination. If the system's recall to identify risky diagnosis can be high, then I consider this system can be very valuable. So in addition to just improving reasoning ability, our research also try to model emotions into chatbot, because a carebot not only need to provide like medical information, but also need to be expressing caring and empathetical behavior. And because of time, we don't have slides to present right now, but you can examine our recent papers, COCOMO, which aims to develop a conscious layer on top of LLM. And we have done experiment in Stanford, develop this neural system, try to encode empathy into the dialogue. And we are hoping by improving this AI system, and we can improve everybody's health and making everyone a better version of yourself day after day. Thank you so much for your attention.